The reason for that is that there has been a lot of lack of awareness about pediatric endocrine disorders. So we started off with workshops and practical courses which were held across the country. Then we realized that it was very difficult to cover large areas because it is so much logistically difficult. So we started off with social media, particularly with YouTube. And then we started our fellowship program. Now we have got, today we have now got around 10th fellow. Dr. Dhwani has joined as well. So we have got now 10th fellow in our system who has joined the CDR program. Then we started off with our online courses and then finally textbooks and mobile applications. So we have tried to take forward in terms of making it easy and easily available and accessible in that regards. We have conducted a number of courses. The first practical pediatric endocrine course actually happened 10 years ago. So since then, we have got a lot of physical programs, but we also now have a lot of online programs which are there. So this is the third online program which we are doing because this provides a much wider access across the globe in that regards. We have our YouTube channel, which has got large number of videos which provide information about every aspect of pediatric endocrinology. There's also an online course which covers various aspects using validated tools. And we have got special courses, including the pediatric endocrinology for fellows, for postgraduates, fellowship in pediatric endocrinology, and a number of programs which are available online, which you can access through our website. We also run routine, regular postgraduate lecture series along with grand rounds using specific cases. So all these are concised in around 8 hours. These ones will run a long time and cover the entirety in that perspectives. And we have got publications which you can access and our mobile application, which will also showcase how it helps in terms of making point of care assessment and diagnosis possible. We are in the process of developing and probably will launch soon about our personalized intelligent EMR, which will allow our overall aspect of care using minimal inputs. Patients will get detailed output with regards to the likely diagnosis, likely evaluation and management. This will make connected clinics through using the e-system, making it much easier to whatever has been learned to implement in that regard. So recently, we have got a lot of programs. People have joined the fellowship program and the diploma program as well. So coming specifically on this international practical pediatric endocrine course, we have got this 2-day program. First day is dedicated today on office endocrinology. We'll be covering growth, thyroid, puberty, and DSD. And tomorrow we're going to cover the endocrine emergencies, mainly calcium, electrolytes, decay, and hypoglycemia. So 8 modules. Anjali, Dr. Vikas from Aligarh, who has been working a lot with regards to pediatric endocrinology. Dr. Hemang, I'm specifically taking his name as a stalwart because he has developed a validated mobile application which guides each and every step of management of decay. And we'll talk a bit about how he developed that. And Dr. Naveen, who has just recently passed out, and he is currently in Lucknow. I'll also be joined by Dr. Sayan regarding the case presentation in the grand round. So we will start with this unfortunate case. 4-year-old girl who received fluid and insulin from outside, had hypokalemia, was given normal saline and then was given insulin. Now what happened is suddenly she developed hypokalemia and arrhythmia. So the problem here is that there was significant hypokalemia which was missed, and that had a lethal consequence. So we need to be wary that DKA is common. We have always been told that India is a country with low prevalence of diabetes. So it's actually not low prevalence. It is basically not picking up at the right time. So this is something which is very, very important, and we are missing a large number of children in that regards. So just to touch base on, DKA basically is insulin deficiency and counter-regulatory excess. Both of them play an important role in the pathogenesis. Insulin deficiency causes ketosis, so you have lipolysis, you have ketogenesis, and ketones cause acidotic breathing, abdominal pain, fruity odor, and all the other problems from there. While counter-regulatory excess and insulin deficiency will cause increased process of glycogenolysis and gluconeogenesis, causing hyperglycemia, which then causes osmotic diuresis, causing loss of sodium, potassium, water, phosphorus, and a lot of other compounds along with that. So you have a combination of ketoacidosis on one hand, and you have severe dehydration, which is responsible in this scenario. So what happens with DKA? We all know that there is dehydration, but that is 7 to 10%. We, however, do not appropriately clinically assess hydration because there are problems. If you look at tongue, it may be more dry because the child is breathing. If you look at skin turgor, the child will have increased osmolarity, so skin turgor may be preserved. So most important measures are capillary refill and blood pressure and oliguria. Then the other thing to remember is that we often say go low in terms of hydration. Second is if a child with DKA has shock. Shock is unusual in DKA because there is a counter-regulatory hormone excess. You've got a lot of epinephrine, you've got a lot of cortisol, you've got a lot of AVP. So why would shock develop? Is there is something else going on. So you have to be worried about in that perspective. Now, there is, of course, a significant sodium deficit, but we tend to overestimate the deficit. Remember the last session, we said that for every 100 milligram per DL rise in glucose, the sodium goes down by 1.6 to 2. You can use any of these criteria, and that is important to remember to use a corrected sodium in that scenario. The third important thing is potassium. There is a huge potassium deficit, but we tend to underestimate the potassium deficit because of metabolic acidosis and insulin deficiency, potassium has come out of the cell. Once you treat, this potassium will go in, and for every 0.1 decrease in pH, the potassium goes up by 0.6. So if you have a pH of 6.8, the potassium should actually be subtracted by 3 to 4 points. So you should know that even if your potassium is 5.5, you are sitting on a severe depletion of potassium, and that's a very important message in that perspective. So be wary about potassium in that regard, and this is the formula I was talking about. 7.4 minus pH into 0.6. So for every 0.1 decline, 0.6 is the increase in potassium which happens in this scenario. Very important message: if you have severe DKA, think phosphorus. Because if you do not give phosphorus at the right time, you will develop rhabdomyolysis, which will cause renal failure. If you have refractory hypokalemia, look at magnesium level, which is also very important. Now, treatment, of course, you give fluid. Just by fluid, you are expanding the volume and you are reducing the counter-regulatory hormones. Your glucose will come down typically by around 100 to 200. Then you start insulin and you will then lose the potassium. The glucose will further come down and your ketosis will come down. If you give too much fluid, you may cause cerebral edema, you may cause hyperchloremic acidosis. If you give too much insulin, you will cause hypokalemia, and that also can be dangerous. So the balance is not doing too much while not doing too little also, and that's something which is very, very important in DKA. So what are we bothered about? If you give too much fluid, if there is a severe disease, if somebody gives soda bicarbonate, there could be cerebral edema. Remember, cerebral edema can happen right at diagnosis in DKA, and this particularly happens if people have been treated outside. Anybody who comes to you with DKA who has got altered sensorium, low GCS, think that cerebral edema may be there. Other markers are pH less than 6.9 and a CO2 level which is less than 10. CO2 level should never be less than 10 because whatever bicarb is, if you correct for it, it should be more than around 11 or 12. So a CO2 less than 10 indicates a hyperventilation. So there is something going on already, and that's something which is important. So you have to worry about that because this is a high mortality morbidity. Very importantly, give less fluid, slower correction to prevent, and we'll discuss about that. And mannitol can also be effective. Now, hypokalemia will happen if you give insulin. So you have to supplement potassium. So every child who is having DKA, give 40 millimoles per liter of potassium. If you have a child who has hypokalemia at presentation, like the first child, start potassium in the hydration fluid. That's very, very important. And very importantly, if you have persistent ketosis, if you have infection, if you have too much chloride, you will also develop hyperchloremic metabolic acidosis, which you have to worry about. But do not give soda bicarbonate unless the child is dying because of severe hyperkalemia or there is a problem like a cardiac compromise. That is the only indication where soda bicarbonate is required. Be wary of infections. So if you have fever, it is again a cause of concern. High counts may happen as part of DKA. I've seen 30,000, 35,000. Don't worry immediately. But if you have fever, there is a cause of worry. Very importantly, it's a hyperosmolar state. So do not put a central line. If you have to put a central line, give a low molecular weight heparin. That's very, very important. And if suddenly the child develops leg pain, hematuria, oliguria, think of rhabdomyolysis, typically because of hypophosphatemia in that scenario. So now we'll start off with the first case. Dr. Sayan will take over from here.
Thank you, sir, for taking us through the summary of diabetes and its management. Moving forward to the first case, this was a 4-year-old girl presenting to us with severe decay. Now, was managed as a case of diarrhea. So given various amounts of fluids and referred to us. Now, on presentation, had severe acidosis at pH of 6.8. Bicarbonate was almost undetectable at 4, and ketones were very high at 7.1. On presentation, was drowsy and had anisocoria. Also had brisk reflexes. So, Dr. Anjali, could you tell me the immediate management that we need to do at this point of time?
Thank you. This is a 4-year-old girl with severe DKA, managed as diarrhea. On examination, child was drowsy, anisocoric, with brisk reflexes. Can you hear me?
Yes, yes, yes. You're audible.
Okay.
Yes.
This is a case of severe DKA with cerebral edema at the time of diagnosis itself. So beware of fluid therapy, prior fluid therapy.
Yeah.
Okay.
Yes, yes. And any immediate management that you would like to give in this case?
We should immediately give mannitol as soon as we diagnose cerebral edema.
Yeah.
And also, fluid should be given in a slow manner, over 72 hours.
Yeah. Yeah. So what are the giveaway messages that you would like to tell us?
As in this case, we should always be beware of prior fluid treatment and also watch for cerebral edema at any time during the DKA management. And also, slow correction of IV fluids is required in order to prevent cerebral edema.
Yes, so thank you for this wonderful message. This also, sir, tells us that every time when the patients present to us, at any point of time suspecting cerebral edema, give mannitol straight away. Don't wait. And thank you for wonderfully taking us through this case. Now, moving forward to the next case, we have an 11-month boy presenting to us with failure to thrive. Had a pH which was pretty low at 7. Ketone was high at 4.4. Had a random blood glucose of 440. So, Dr. Vikas, is this decay and how will we manage the same? Dr. Vikas? Dr. Vikas, can you hear me? So moving forward with this case, so this was a 11-month-old boy with high sugars, pH low and ketones high. So this is actually a case of DKA. Now, will we give bolus is the first question. Now, as this child doesn't have any features of cerebral edema, we will move ahead with the bolus in this case. Now, the duration of therapy, as this is a very small kid. So
I think this is an interesting case scenario because we are dealing with a situation wherein we have got a very, very high risk. In particular, what we're looking at, as Dr. Saini said, that this is an infant. So of course, we have to give a bolus in this scenario, but the duration may be more long because we don't want a very rapid correction. Insulin also, we want at a lower dose because now many people actually consider 0.05 as a low dose, as a standard dose also. But in infants, we want to use a lower dose and we have to worry about cerebral edema. I think that's a big message coming from there.
Yes. So moving forward to the next case. Now we have a 9-year-old girl who is very emaciated, having a random blood glucose of 600. Again, pH low at 7.1, ketones high. So this is again a DKA girl, but she's very emaciated. So Dr. Hemang, any modifications to the protocol that you would suggest in this case?
Am I audible, Dr. Hemang? Dr. Shayan?
Yes, sir, you are audible now, sir.
I was right from beginning.
Okay, so we couldn't hear you in the next case. We will...
No, sure. Please carry on.
Yeah, thank you, sir. So Dr. Hemang, can you hear me?
Thank you, Dr. Sayan.
Yeah.
I can see this is a 9-year-old girl presented with hyperglycemia, acidosis, and ketosis. This case is a case of a DKA. So yes, we will start management with fluid boluses, and duration should be over 48 hours. But the child is emaciated, so we should start low dose insulin to because this child might have a low potassium reserve. So to check for hypokalemia is the first thing, and we should start with the low insulin dose, and we should aggressively look for the hypokalemia, as well as sir says as hypomagnesemia could be one of the cause. So potassium and magnesium should be kept watch in this case.
So a very important point you told us. So two modifications. One is if an infant and emaciated child, which should start with low dose. And as you very well mentioned, low potassium along with low magnesium, we should always be careful of. Thank you, Dr. Hemang. Moving forward to the next case, we have a 3-year-old boy with severe diabetic ketoacidosis. Now, this is different from the other previous cases. This was managed outside as DKA for 6 hours. Had a pH which was 6.9, bicarb, undetectable, ketone still 6.4, but also had a very low potassium at 2.8 millimoles per liter. So, Dr. Naveen, are you here?
Thank you, Doctor.
Yeah. So,
Thank you, Dr.
how would you
Sen.
like to manage this case?
Thank you, Dr. Sen. This is a 3-year-old boy who was managed in the peripheral setting under the as severe DKA. And we also have one of the dangerous complication of DKA as hypokalemia here. This could probably because of the fact that the potassium was not administered during the initial management. So potassium is something that is very important, and we need to identify the potassium level during the management of DKA. So based on the potassium level, we need to assess the potassium and we need to start on the therapy. In case if the potassium level is less than 3.3, then we need to give potassium supplementation immediately in the hydration fluid, which was discussed in the earlier presentation by Dr. Anurag. And when the potassium levels is between 3.3 to 6 millimoles per liter, then we need to add potassium in the maintenance phase. And if the potassium level is more than 6, then we can defer potassium and start potassium in case the potassium level fall down during the treatment, which is expected because of the insulin therapy. So in this case, so first thing I would like to say that we need to start potassium immediately in the hydration phase, and we may also would want to defer insulin until the potassium normalizes. The second thing with regard to the administration of potassium, in a patient with severe acidosis, as already mentioned by Dr. Anurag, we also expect hypophosphatemia. So we would like to administer potassium as 50% potassium chloride and 50% potassium phosphorus, which would take care of also of the hypophosphatemia. And third thing, in a condition of insulin deficiency and metabolic acidosis, the most common thing which we encounter is hyperkalemia. But hypokalemia in such a situation requires ruling out the possibility of celiac disease. And in this case, I would like to rule out celiac disease during the immediate follow-up. So hypokalemia is very common, but it is not seen at the initiation. It is usually seen during the management course. And if the patient is having hypokalemia at diagnosis, it can result in pulmonary arrhythmias and sometimes possibly disastrous consequence. So based on the high potassium levels, we need to start potassium immediately in the hydration phase if the potassium levels are less than 3.5. And this being a very common scenario, how can we improve the quality of care? I would like to request Dr. Hemang to emphasize on improving the quality of care.
So I think this was a big challenge because despite having a written protocol, when we were trying to look at our own audit, we were not finding that there was a good result. A lot of changes were done, and especially when you have the initial treatment written, in the first hour, as we always say, golden hour, if you are missing the treatment, you will have a problem. So Dr. Hemang, we came up with a brilliant strategy. Dr. Hemang, can you please brief about your work?
We have gone through 100 cases of diabetic ketoacidosis, and we have evaluated. In only 18% of the cases, we have found that there was no error and child was managed 100% as per protocol. But the rest of them, there were several errors like we missed the boluses, or fluid calculation error was there. We have given less potassium, or delayed initiation of the dextrose despite having a hypoglycemia. So in 17% of the patient may have 2 or more errors. And 3 important complications of hypoglycemia, hypokalemia, and dehydration management. 68% of the hypoglycemia 42% of the hypokalemia and 66% of the dehydration can be prevented if we stick to the protocol. So how to stick to the protocol? So we have developed one MedEClasses endocrinology mobile app in which you have to enter a date of birth, weight, blood sugar, ketone, and all the necessary parameters. And at the end, you just have to click and it will guide correct management for the case of diabetic ketoacidosis.
हाँ हाँ तो बात
So as we
उत्तर
see,
मोलाव कर लो
yeah. So and another thing is one of the
देखो और
follow-up
कम
case.
करो
How to
43
follow?
रुपए ऐसा
So after
कहना चाह रहे हैं आप
since how many hours of the admission you are looking at the patient, you just need to enter weight, blood glucose, initial sodium, initial GCS, and current GCS, current sodium, and current glucose. It will give you a fall in serum osmolarity more than expected, and whether your child is at the risk of cerebral edema or not, and how to modify your current management. And this app will help to point to it will help as a point of care guide to manage DKA strictly as per protocol.
So I think that is a wonderful input which Hemang has developed. It's available in our mobile application. It really helps in terms of point of care management as far as latest guidelines. It provides guidance for immediate and follow-up care in that scenario. So this is how we can think of improving the quality of care. So carry forward from there, Dr. Sain.
Thank you so much, Dr. Hemang. Moving forward to the next case now. This was a 10-year-old girl, very high blood sugars at 540, body weight of 30 kgs at presentation, had metabolic acidosis, pH of 6.9, dehydration at 10%. So Dr. Anjali, kindly tell us how to manage this case from here on, a fresh case presenting to us with DKA, severe dehydration.
Thank you, Dr. Sayan. This is a case of severe DKA with dehydration 10%. Here, pH is less than 7, bicarbonate less than 5. This should be treated in an ICU setup. The markers of severe DKA are low CO2, high lactate, high anion gap, high blood urea nitrogen. ICU admission is indicated in pH less than 7.1, age less than 5 years, with altered sensorium and low CO2.
Yes.
And also fluid should be given during the next 48 hours. According to IPPEC guidelines, we should calculate maintenance plus deficit. Maintenance should be calculated according to 4-to-1 formula, that is 70 ml per hour, and deficit by from dehydration. We are considering dehydration as 10%, then 62.5 ml per hour.
Yeah.
Then the total fluid should be 135 ml per hour, should be corrected in 48 hours.
Yes.
We should correct slowly in order to prevent cerebral edema.
Yes, Dr. Anjali, thank you so much for taking us through the calculations. But Dr. Anurag and Dr. Hemang has also come out with the DKA initial applications where you just have to enter the initial parameters, pH, ketones, blood sugar, age of the child, PCO2, and the potassium, and you get a direct prescription immediately. And this is how they also showed via their research that this can cut down on the errors that we are committing and taking the patient to complications. Yeah.
Let me give output in that form.
Yeah, this is the output that you will get, and you can immediately start management on this format. So this will cut down on the errors that we are committing in spite of the availability of guidelines. Yeah. So, So Dr. Vikas, we have now started the initial management of the child. Now, coming to monitoring, what are the things that we should keep in mind during monitoring this child with severe DKA at presentation?
Thank you, Dr. Sayan. Basically, DKA is a situation where you cannot have a morning and evening round. You have to have a very close monitoring even after the initiation of the initial treatment plan. And as we can always see that monitoring is of two parameters. One is clinical monitoring, other is lab monitoring. Clinically, you should look for the sensorium, you should look for the heart rate, you should look for the blood pressure, you should look for the hydration phase. So always have a close watch on the sensorium of a child Is your child is irritable? Is your child is very well oriented in the time, space, and person? Any sudden deterioration in the neurological sign? Any cranial palsy? So you have to act very fast and identify all the pointers of the DKA, all the pointers of cerebroedema. Secondly, look at the hydration. Hydration, you can see about the if the child is passing urine adequately around 1 ml per kg per hour, you can be assured that your child is very well dehydrated, very well hydrated, because you cannot afford cerebroedema, dehydration, and oliguria. Now, apart from your clinical assessment, watch for tachycardia again, watch for blood pressure again, because blood pressure is the only sign of hydration state of a child. Think about the lab parameters. And as far as lab parameters are concerned, there are 3 lab parameters which is very, very important: your pH, your sodium, and your potassium. You should at least, initially, you can have at least hourly watch on your sodium, potassium, and pH part. What is expected and what is going to happen with the child. The moment you start the treatment, you are expecting your sodium will go up. But you have to be very, very careful that any rapid incline in the sodium in a setting of polyuria is again, you are going for cerebroedema. So watch for sodium. It should not go very high. It should not go very high and very early. So watch for your sodium and always use corrected sodium as talked by Dr. Anurag Bajpai, sir. Always interpret your lab report with the clinical setting. Secondly, your potassium. What is happening is whenever you receive a child in the DKA, initially only after hydration, proper hydration can reduce your hyperglycemia and acidosis. So always, think of twice before adding insulin to start with, and always start your treatment with potassium. Monitor potassium. What is expected is that the moment you start insulin, your potassium will go down. So always monitor potassium. It should not go down very, 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 very fast. And if you are seeing a rapid decline in the potassium, add potassium in a higher dose to every child to avoid the life-threatening hypokalemia. Secondly, monitor the pH of a child. What is happening is the moment you start correcting the dehydration and hyperglycemia, your acidosis part should improve within 12 hours. But whatever, if you are seeing your pH still goes low, your acidosis is persisting, think about hyperchloremic metabolic acidosis or lactic acidosis or shock, or you can say insulin deficiency. So monitoring pH, sodium, potassium, and clinical status of a child will go a long way towards the outcome of DKA. Thank you, Dr. Sain.
Thank you so much, Dr. Vikas. And this is the recurring theme that is coming to us, that potassium will immediately decrease. And I can't tell you the exact percentage, but more than 50% children have potassium which is low during admission and on the course during hospital admission. So we have to be very careful about potassium. And this child, after 4 hours, had a blood sugar which was 650. So blood sugar which was still persisting high, and base excess was -22. So Dr. Vikas, do we need to think about anything we are missing in this case? Blood sugar is still high.
Still, we are seeing that there are 2 situations going on. We are having a persistent acidosis as well as the hyperglycemia. So we have to think about our insulin regime, whether we are giving too less insulin, or whatever insulin we are giving, it is binding to the tubing, or we have to increase our infusion rate. So always, what you should do if you are having a persistently high blood sugar and acidosis, always freshly prepare your insulin, change your tubing, and flush the tubings with insulin, and then assess again your child as far as the blood sugar and the acidosis is concerned.
Yes.
Dr. Shine.
Yes. So thank you, sir, for these wonderful pointers that you have given us. And sir, the child also went into shock.
Yes.
Okay, sir.
So this child is not responding, probably because of dilute insulin and insulin binding to tubing. So always flush. So when we flush, what we find the science subsequently is.
So according to what Dr. Vikas said, now we corrected we flushed the tubings, and we find that the blood sugars have now decreased from 650 to 190, and the base excess also had started to improve. So Dr. Naveen, now what do you think about this case now? Is the child doing fine?
Yeah. Since 8 hours, it has been since the initiation of treatment. This is a very common finding that we usually anticipate during the management of diabetic ketoacidosis. First, there will be a fall in the blood sugar level, which usually takes around 6 to 8 hours, followed by fall in the ketones level, which usually takes around 10 to 14 hours, followed by resolution of acidosis, which usually takes around 16 to around 1 day. So this is quite a normal finding. And with regards to the blood glucose level, we need to monitor hourly, and we need to titrate the dextrose content rather than stopping the insulin level. In case if you're stopping insulin in such a scenario, it will cause worsening of ketosis as well as acidosis. So we need to monitor the dextrose blood glucose level, and we need to add dextrose.
So how much do you recommend to add?
In case if the blood sugar levels is below 300, I would like to add dextrose 5%. And if the blood glucose level is less than 200, then I would like to add dextrose of 10%. So in this scenario, we have a blood glucose level of 190 milligram per deciliter. So I would like to add dextrose of 10% in this child and serially monitor the blood glucose level. And I will also emphasize on the fact that we should not stop insulin because it will cause worsening of ketoacidosis. And so this is a very common
persisting
finding.
Acidosis is not a matter of concern at this point of time at 8 hours, right?
Yeah.
Yeah.
That is what the message
So,
is.
okay, we'll add 10% dextrose and continue insulin as you just said. Then at 10 hours, we find the blood sugar is doing fine at 220. Base excess is -11, but just see the potassium. It has started to decrease and is now at 2.6. So, Dr. Hemang, any modifications to the management at this point of time that you would advise to us?
Yes, at this point of time, actually, due to hypokalemia is more dangerous than correcting the acidosis. So at this point of time, we should decrease the insulin and we should increase the potassium supplementation. And as the sugar is 220, more than 200, we may just switch to the 5% dextrose.
Yeah. Yes. So we did switch to 5% dextrose and he was getting 40 millimoles. So
we should shift to 60 millimole per liter per hour.
Okay.
60 millimole per liter of potassium supplementation in this case. And we reduce
this is often a very big problem, and often we get potassium less than 2. So how rapidly we can correct, and will you suggest some sort of a protocol for infusion of potassium? Because this can happen especially with outside treated patients.
Yes, sir. In such scenario, we may just stop the insulin level for if it is around 2.5 or less than 2.5. It may lead to dangerous arrhythmia. So we should give a rapid correction of potassium over 1 hour or 2 hours. That's one easy method to give is weight divided by 4, and that amount to be given hourly for 1 to 2 hours. That will correct the sodium and bring it above 3. That will be less dangerous, and we may start then low dose of insulin and recheck the potassium level.
I think that's very important. So 0.3 to 1 millimole per kg per hour can sometimes have to be given. We just gave in that patient who was such severe this thing. So this is an important message. And I would say cellular edema is something which is becoming a bit less, but hypokalemia is now becoming a bigger problem. So you have to be a bit bothered about hypokalemia.
Thank you, sir. And thank you, Dr. Hemang, for the additional inputs. So now moving forward with this case, at 14 hours, this girl becomes comatose. Dr. Anjali, what do you think is happening with this child? Everything was doing fine, sugars, pH, everything is doing fine, but suddenly she becomes comatose.
Okay. Thank you, Dr. Sayan. This is a case of severe DKA with clinical deterioration. We should always be prepared for cerebral edema at any time during the management of DKA. There may be rapid fluctuations in sugar. A rapid decline in sugar will lead to osmotic shift and cerebral edema.
Yeah.
As already we discussed in our first case, we already seen cerebral edema was diagnosed at the time of admission itself. Yes. So we should prepare for cerebral edema management at any time during the DKA management. So we should give immediately mannitol 2.5 ml to 5 ml per hour in order to prevent cerebral edema.
Yeah.
And sign body. Yeah. Please go ahead. Please go ahead.
Okay. Waiting for imaging would be lethal. So we should give immediate mannitol as we suspect cerebral edema. Okay, thank you.
There is now often a debate whether you give 3% saline versus mannitol. What do you prefer?
So this is, as you always say, mannitol has two effects. One is it decreases the cerebral edema, but also changes the nature of vasculopathy that occurs.
So there is a big debate as to what really causes cerebral edema in DKA. Some people always stick to that. There is a vasogenic theory. So you've got this shifts which is happening, and all that osmotic shifts may be there, but it is a direct perfusion, hypoperfusion, reperfusion injury, just like birth asphyxia. So many people say, and in West, what is happening is that what they say, whatever protocol you follow, whatever fluid you give, there will always be a percentage who will have cerebral edema. Alike, they say that whatever you control birth, the birth asphyxia, some people will have birth asphyxia. Same thing they say like that. So probably there are two components working. One is a osmolar component, the other is a vasogenic component. So mannitol is good for both cytotoxic damage as well as osmolar damage. So mannitol is always preferred over 3% saline. So anybody who has, as Dr. Anjali said, somebody who has got DKA in the bedside, have mannitol, have 10% dextrose. If the child doesn't have hypoglycemia, give mannitol. Don't worry about that. Carry forward.
Yeah, as you just said, waiting for any imaging would be lethal in this case. An immediate measure would be to give mannitol. So thank you, Dr. Anjali. And this is the paper that Sir and Dr. Neha did. And what they found is that the maximum proportion of cases having cerebral edema will present to you at admission. And these cases will generally be treated outside. But as you saw in the previous case, and as Dr. Anjali mentioned, you always have to be prepared for cerebral edema at any point of time. And as you see in the peaks on the left-hand side, the peaks occur at 16 hours, 24 hours, can occur up to 60 hours. So be ready for cerebral edema at any point of time during management.
And the other thing is that the major predictors which we saw were somebody who had a new onset diabetes, because they are often more severely affected, and somebody who has received treatment from outside. So I would say three things outside treatment: pH less than 6.9, CO2 less than 10, always be very cautious. And if your GCS is low, I'm really scared this could be cerebral edema, and I want to be a bit slow in that perspective.
Yes. So the same case, after managing for cerebral edema, does fine. Recovered from comatose state. Blood sugars again going on the lower side at 120. pH improving, base excess but still persisting. So Dr. Vikas, anything else that we should consider at this point of time?
See, thank you, Dr. Sayan. See, what is happening is at 20 hours, the child is hemodynamically stable. Sugar is okay, 190, and base excess is improving, but still it is high. So what is happening is the acidosis part is persisting. So we should check the ketones. And in this setting, if the ketones are negative, and again with the negative
1.4, sir.
So ketones are negative. That means we are not getting ketosis. We have got only acidosis.
Yes,
in a otherwise stabilized child. So we should think about the hyperchloremic acidosis. Even we do not have to have the lactic acidosis, which should be less than 32. So any new protocol should not be done in this case. Just wait and watch. And if still it is persisting, we can change the fluid from normal saline to lingual lactate. But usually this is a self-limiting condition. But again, you should have very, very close watch on the hemodynamic status of the child and keep waiting, and this will resolve by itself.
Yes, so the hemodynamics was doing fine, and the chloride load, as you just said, came out to be 38.
Okay, so again, it's confirmed the diagnosis.
Yes,
hyperchloremic
acidosis. Need to wait and watch at this point of time, sir. And
yes,
for the blood sugars, we'll go ahead with adding 10% dextrose.
No, though this is a tricky situation, because if you are stopping insulin right now, then the acidosis part will persist. So, and again, on the one hand, you have got hypoglycemia, on the other hand, you have got insulin infusion. So what is the protocol is, as Dr. Bajpai has said, you should add the dextrose, keep titrating your blood sugar, and delay and continue with the insulin infusion till you are overlapping the subcutaneous insulin.
Yes, sir. Thank you, sir. Thank you.
I think that's a very important message. Another thing to remember is that now this is 20 hours. So by this time, we should expect the ketoacidosis to have gone by this time. So I would be going a bit step further, try to maybe add dextrose and reduce insulin also, because he's not having a much problem because of ketosis. We reduce the insulin and try to taper. If this is at night, maybe give a long-acting insulin right away, because this is something which will reduce the duration of overlap and you will have a better outcome coming from there. One parameter which you have mentioned is chloride load, which is an indicator of how much is the chloride. Now, Dr. Sayan, how can you prevent hyperchloremic acidosis, or what steps can reduce the development of hyperchloremic acidosis?
So we can start with N/2.
So you can start with a half normal saline, or you can start with plasma light. You can start with Hartmann solution, which has got a lower amount of chloride. You can use potassium phosphate as half correction instead of potassium chloride. We haven't discussed that part because we discussed a lot about potassium. Now, standard guidelines have long said use 50% potassium phosphate, 50% of potassium chloride. But in India, potassium phosphate was not easily available. Now we have got potassium phosphate, which is available. So anybody whose pH is below 6.9, we definitely should give it. Otherwise, also you can use 50-50%. You will prevent hypophosphatemia, and you will also not cause a lot of hyperchloremic metabolic acidosis, because this is one condition, and often people continue insulin for a long time. It is not needed in this scenario.
Thank you, Dr. Vikas, and thank you, Anurag sir, for this wonderful message. And moving ahead now.
Yes.
Yeah. So at 28 hours, the base excess has reduced. It has come down to less than -5, and blood sugars are 170. The child is conscious. So everything is going fine. So Dr. Hemang, what are the things that we should do now? Should we wait further, or should we do something else and switch the child to oral feeds?
Yes. So child is conscious, and sugars are well controlled, and acidosis has resolved now. So at this point of time, we may think to switch to the subcutaneous insulin.
Okay. and we should allow orally also?
Yes.
Okay.
So
yeah. Kindly
so
take it forward. Yeah. So we started the patient on regular insulin. And this is the case I had managed when I just came. I started the patient on regular insulin, and I stopped the fluid and insulin immediately. And the sugars after 2 hours came out to be 560. So do you think I did something which was not appropriate at this point?
yes, Dr. Sayan. What we should do is switching to the subcutaneous insulin should be an overlap process. And if we allow orally, and actually, first thing, switching of the insulin should be done around the time of major meal. Meal should be available. Second thing, we should continue fluid and insulin till 1 hour after we have given subcutaneous insulin. And till that time, we may just continue low dose insulin, so that a smooth overlap of the subcutaneous intravenous to the subcutaneous insulin transition occurs.
Yeah.
And one more thing which Anurag sir has mentioned is, we may, if we think that child is stable enough to switch to the subcutaneous insulin, one day prior to that at night, we may just give a longer acting insulin, so that child have a basal, a steady amount of insulin in his blood. And it will further smoothen the transition from the IV to subcutaneous insulin.
Yeah. So 2 points that you just raised: a child stable, conscious, pH is normal. We can give him long-acting insulin 1 day prior, and to overlap. These are the 2 messages coming out from what you said, Dr. Hemang. Thank you for the same. And moving forward now, post DKA, we changed to sliding scale, 2 units per kg per day, and there was random sugars going low, going high, no control over the same. So Dr. Naveen, do you think I mismanaged this as well?
Yes, Dr. Sai, because sliding scale is not recommended, and it is not wise to give insulin based on the preceding blood sugar level in a child with type 1 diabetes. And it is very important that we need to start the child on basal bolus regimen rather than using sliding scale for the administration of insulin. And with regards to the dose of basal bolus regimen, because of glucotoxicity and acidosis, the requirements may be very high. It may even be around 1.5 to 2 units per kg per day. And we also need to counsel the parents regarding the fact that during the initial phase of management, we can have fluctuating blood glucose, and there can be a drastic fall in the insulin requirement from 2 units to even less than 0.5. So we need to counsel them regarding the various complications such as hypoglycemia, regarding the various warning signs of hypoglycemia, and also we need to encourage them regarding the meticulous monitoring which is required in the early phase, and we also should educate them regarding the fact that the insulin level requirement will fall down during the initial phase.
Thank you for this message. It is not that as per the textbooks which we followed during our residency, it was mentioned for a 10-year-old girl, 1 to 1.2 would be the requirement. But as you very well mentioned, it can be 1.5, 2. And in this child, we actually gave 2.5 units per kg per day.
So why do you think the requirement is high, Dr. Sayan, to begin with?
So just Dr. Naveen just mentioned, due to the glucotoxicity and the lipotoxicity, the remaining cells don't function and there is a level of resistance.
But even if you have no cell functioning, your requirement should be 1. Why is it 2.5?
So the insulin post-receptor action is difficult.
So resistance. Yeah. So there is also resistance as well as deficiency. And within 4 weeks, we expect that there will be a reduction of at least 60 to 70% in terms of insulin requirements. You have to be very cautious in the initial phase to assess in terms of how much insulin is to be given in that regard. So I think that's a very big message, that start directly from a basal bolus. In fact, you give a basal right at night. Don't wait at that point of time. And again, wait for at least 30 minutes. That's very important from even the rapid acting insulin and this thing. If you are giving a short acting, wait up to 45 to 60 minutes for it to start acting in that regards. Otherwise, you will have low and high. Sliding scale is a reactive strategy. It is something which should be actually be stopped, not recommended at all in that regards. So just to get an overview about DKA management, we've already discussed that it has got 3 phases. The first phase is about hydration. You give 10 ml per kg normal saline. And now the recent guideline, which was just released yesterday by the IPPEC, they talk about giving it over 20 to 30 minutes. And they say that if you have a rapid, somebody has a shock, you can repeat it if required. Very few changes which have been done compared to what we have discussed today. So it's pretty much in sync with the IPPEC 2020-22 guidelines. The next step, of course, is to correct deficit and maintenance over 48 hours. And insulin at 0.1, you can use 0.05 unit per kg per hour, especially if there is malnutrition and if there is emaciation. Very importantly, always add potassium unless there is anuria, hyperkalemia or ECG changes. If somebody has hypokalemia at presentation, start right in the hydration phase. If you have a blood sugar below 300, add dextrose. Do not give soda bicarbonate and monitor for cerebral edema. Now, this is my favorite side. So always you have to look at in DKA, you have to keep a balance in terms of management. If you give too little fluid, you will basically have a dehydration. If you give too much fluid, you will have cerebral edema. If you give too little insulin, you will have a delayed course of correction. But if you give too much insulin, you will have hypokalemia. So I think if somebody has to decide whether you want to have a delayed presentation, some dehydration, some long-term treatment versus having cerebral edema, hypokalemia and death, there is no choice between the two. So the key concept of DKA in this current time is basically go slow, do not have a very rapid correction, less amount of insulin, less amount of fluid in that perspective is what we are recommending in that regards. So I think this was a wonderful discussion and we were able to quickly go through the various aspects. I'd like to thank Dr. Hemang, Dr. Vikas, Dr. Naveen and Dr. Anjali along with Dr. Sayan for having allowed such a wonderful discussion. We'll see if there are particular questions in that regards. So we've got Dr. Bharani again from UK. He is asking in DKA with severe hypokalemia less than 2.5, is there a role of calcium gluconate to reduce cardiac arrhythmias along with potassium correction? So Dr. Hemang, what is your take about giving calcium along with the potassium correction? So the key question is whether calcium can also have a cardioprotective effect in hypokalemia also, as we already know it is there in hyperkalemia.
Yes, as sir already said that in hyperkalemia, we need to give calcium as a stabilizing agent. But in case of hypokalemia, I doubt is there any role of calcium gluconate to stabilize the cardiac membrane. And just correction of potassium will reduce the risk of cardiac arrhythmia.
I think the most important thing again here will be the potassium correction, which is the pivotal role. Calcium will not have a huge impact in that regards. Now, another question which has come from Dr. Gayatri is about intubation in DKA. So Dr. Vikas, what do you think about when should we consider DK intubation, early or late?
Late. I think we should avoid intubation because there are some studies which has been categorically proven that intubation will trigger the cerebral edema. So now we are switching more and more towards non-invasive ventilation, if at all it is required. Your take, Dr. Bajpai.
If you do an intubation, you have a risk of causing paradoxical CNS acidosis. You may cause worsening. So we should try to defer it as long as possible. So few things which you should not do in DK is not to put a central line, not intubate, and very importantly is that do not give potassium. That is something which you have to avoid. The other important thing to remember is that you have to carefully look at phosphorus, potassium, and magnesium, and that becomes pivotal and very, very important from that perspective. So, this
Dr. Bajpai,
yeah,
just 30 seconds. I would like to share one of the very important data from my ICU. Before introduction of this mobile application of DK management, we have got 8 admission, out of which we have got 5 unfortunate kids, which we are not able to have a favorable prognosis. And since we start, applicable this mobile app as a mandatory protocol for the first hour, our mortality is almost negligible, and we are able to switch early from intravenous to subcutaneous insulin. So from this platform, I can very well say the validation of this mobile application is very much there, and everybody should make a habit for residents and the first protocol caregiver in the ICUs. This is my own ICU setting, sir.
Thanks a lot, Dr. Vikas, for this wonderful input. And the reason this app was developed was basically to ensure the first dose should be the correct one. The problem is that if we get a call at night, often the treatment is already started. By the time we go there, that there is already a lot of mess which has happened. So the key message is initial correct dose is what is most important. And our app is in sync with the latest guidelines because the changes are very, very minute in that perspective. So Dr. Hemang, I think, deserves a big applause.
Yes.
And he has done a lot of wonderful work. Along with Mr. Shalabh Dikshit, who was involved with regards to the technical part. So I think a big round of applause to Dr. Hemang for doing this. And it's already been validated in our center. And we are looking for a multi-centric validation also, which we'll probably carry forward in that perspective. We are also carrying forward this DK protocol or algorithm as part of the PI one, the patient, the person has intelligent EMR. So in app, you can't get a printout. So what will happen is that once you enter the basic data, you will get a full prescription sheet, follow-up sheet, monitoring sheet, and it will become much, much easier. So I think that's a wonderful input from Dr. Vikas in that regard. So Dr. Anjali, any experiences that you'd like to share from your management of DK? So Dr. Hemang, your messages, key messages? We've got a couple of minutes left.
Yes, sir. Actually, there are well-established protocol for the management of DK, but sticking to the protocol is at most necessary to reduce the morbidity and mortality. And we may have a bedside tool which is easily accessible and which may help us to prevent complications which can happen during the management of DK. DK is one of the things, if managed nicely, has a 0% mortality. So I think we should stick to the protocol.
I think that's a big message in the overall theme of our sessions. If we start off with the practical courses that we are doing, the online courses we are doing, and even the application is to really improve the quality of care. That's the main aim. And we want the evidence which is being learned by these courses to be implemented. Because what happens is that if you have learned something, if you don't implement it, it is not a proper use of it. So if you want to have an immediate reminder, these applications are developed in that perspective. So